Thank you very much, Sadaf, and I welcome everyone for today's session. I will try to explain the topic, which as neurologist, and I believe many of the family physician or general practitioners come across. So this is a very commonly seen behavioral disorder, and I will try to share my experience with you guys, and hopefully we will try to learn together. So the outline for today's talk gonna be the definition. We're gonna have a case discussion, epidemiology, risk and precipitating factors for delirium, clinical assessment, laboratory and imaging assessment, beside electrophysiology, and finally we're gonna discuss about the treatment of this condition or how we can prevent it. So definition, delirium is a Latin word which means out of furrow, which means it's a little bit not usual, so out of routine. But in simple words, if somebody want to remember something from today's presentation, it should be this one line: acute impairment of cognition with a fluctuating course. So it's acute, there is cognitive component involved, and it's fluctuating. So these three words are the key words for today's presentation. But according to DSM-5 definition, it's a disturbance in attention and awareness. When we talk about attention, there is reduced ability to direct, focus, sustain, and shift attention. And when it comes to awareness, it's a reduced orientation to the environment. And I'm gonna briefly discuss that more. But delirium in general is divided into two types. One is hyperactive delirium. The other type is hypoactive delirium, and it's good to have this distinction between the type of delirium because the prognosis varies based on the type. Now coming to the basic concept of delirium. So as a general human being or any living being, there is a state of consciousness, which is a state of being aware of and responsive to one's surrounding. But the cognition is a higher mental function which involves mental action or processes of acquiring knowledge and understanding through thought, experience, and the senses. So cognition is a higher mental function and consciousness is a basic awareness of the environment. Coming to my case today, and this patient was actually seen recently as I was preparing this presentation, and you can guess that we come across these patients very regularly in the clinical setting. So my patient was an 82-year-old male who was a known case of dementia for 13 years, who presented with frequent attacks of fluctuating, altered level of consciousness for 1 month, in which he makes irrelevant, incomprehensible sounds continuously. There was asymmetric limb movement, stiffness in the whole body, disorientation in time, place, and person. He was trying to take off his clothes, and there was some urinary and fecal incontinence. But he was able to follow command intermittently. His condition used to stay like this for 2 to 3 hours initially, but it was worsening over the time, and the episodes were longer. He was getting better in terms of after the episode is over, he started responding to the family. There was no jerking or seizures during this time. There was also use of benzodiazepines for his agitation and sleeplessness. And just to share, the family of the patient have some doctors who were suggesting those. There was history of some visual hallucinations. He was feeling that his deceased relatives were visiting him. There was also history of documented seizure 2 years back, but not recently. He had a recent WBC count, and as you can see, this is just from the last month. And his TLC count was normal. His neutrophil count was 58%, which was also normal. His past medical history was significant for hypertension, ischemic heart disease. He had documented dementia for the last 13 years, and as we discussed about in a seizure episode. His routine medications, what he was using at the time of presentation in the clinic, were metoprolol, which he was using for his heart disease, and also trimetazidine, glycerol trinitrate, ranolazine, aspirin clopidogrel combination. But additionally, he was taking painkillers, tramadol and paracetamol combination, and benzodiazepines intermittently for agitation. His examination, if you kind of look through, I tried to cover everything as a neurophysician about what's going on with him. So he looks well. but there was no asterixis. His higher mental function assessment showed that he had no reflexive handshake. He was not oriented to person and place or time, but he do look at his daughter on verbal command. He was having this irrelevant, poorly formed articulation. There was a response to verbal commands. So he transiently look at you, but he doesn't follow the command per se. There was a mild startle response to loud sound. So I like to clap to kind of make sure if there is a response or not. His cranial nerve exam was normal. On motor examination, it seems like he was resisting. Otherwise, there was no asymmetry of upper or lower extremity movements. His reflexes were intact, but he was having extensive plantar reflex on the right side and flexor plantar reflex on the left side. He was not able to sit or stand without support. He was somewhat agitated while sitting in the wheelchair, and additionally there was discoloration of both feet up to shins, but his peripheral pulses were palpable. Now we will discuss about what happened with this case afterwards as we go through our discussion. So why this topic is important. So it's an acute neurological emergency. Almost 10 to 15% of the patients who presents in any emergency department have delirium at the time of presentation. Almost 14 to 56% of the hospitalized patients who are not ICU patients develop delirium in the hospital. So a good number of patient population, based on the population studied, was noted to have delirium during the hospital course. And more importantly, the 40% mortality was noted in patients who were more than 65 years old in 12 months' time. So that's why it is so important to discuss this topic. There is a high risk of developing dementia in the following year. So they may be having some baseline cognitive deficit like the case we discussed, but they need repeated evaluation, especially cognitive assessment after discharge. 50% of the patients develop delirium who are having dementia as a baseline. So a good number of delirium patients develop dementia on follow-up assessment, and a good number of dementia patients develop delirium during the course of their dementia. So the common risk factors, as we can see, is elderly patient, there is a pre-existing medical condition, especially heart condition, ICU or hospital admission recently is kind of a big risk factor for these patients. If they have baseline impairment of vision and hearing, that's an additional reason to get into delirium very quickly. Functional impairment, or if they are bedbound. If they have baseline depression or poor psychosocial situation, malnutrition and alcohol are additional risk factors for these patients to have or land into delirium very quickly. So there are many precipitants, as we can see the list. So it could be a stroke or vascular insult. It could be infection like meningoencephalitis. It could be toxins, trauma recently with subdural hemorrhage, autoimmune conditions, especially Hashimoto's thyroiditis or Hashimoto's encephalopathy, metabolic with the hyperglycemia, hypoglycemia, or electrolyte disturbance. It could be neoplastic with the recent diagnosis of the tumor or unknown tumor. It could be a structural problem. It could be degenerative condition just like dementia. It could be iatrogenic, which is actually very important because these patients, especially with the cardiac surgery and thoracic surgery, which is an additional independent risk factors for these patients to have delirium. But drugs by far, beside infection, are the most common reason to develop delirium, and especially parasympathetic medication can cause delirium very quickly. So we need to be sure about these medication in the medication list. Hospital-acquired precipitants, as I said, a good number of patients who admit in the hospital develop delirium very quickly because there is a sleep deprivation. It's an alien environment for them. They do have catheters or tubes. They may need restraints if there are multiple procedures being done on them. It could be IV line, central line, or whatever. It could be untreated pain condition, which is not letting them sleep. It could be noise and sensory stimulation, which is affecting their sleep time. As we discussed that with this, the importance is high morbidity and mortality of these patients. So it results in prolonged hospitalization, increased mortality, and higher rate of discharge to other patient care institutions. So in total, what happens based on the numbers from US, there is a more than $4 billion of annual Medicare expenditure. So you can imagine how big of a financial burden this condition is. So the clinical characteristics of delirium are very important. as I'll go through them one by one. So these patients, first of all, develop attentional deficits. As we discussed, they have a poor attention span. They kind of flip from one topic to another. They can't have a continuous logical discussion. They may have a hypoactive or drowsy state, or they may be hyperactive. So there may be altered level of consciousness, but that is not primarily a good signature sign for these patients, because that could be the case with other patients as well. But more importantly, to differentiate it from dementia, because the dementia patients don't have altered level of consciousness. It could be perceptual disturbance in the form of hallucinations, delusions, or Capgras syndrome, where they suspect that the family member is some kind of imposter. It could be disturbed sleep-wake cycle, which is actually the first one to be noted. There could be sundowning, so by the end of the day, they become more agitated and start acting up more. And there may be altered psychomotor activity. So they may be hyperactive sometimes, may be hypoactive the other time, sometimes they are appropriately responsive. There will be disorientation and memory impairment that could be part of the cognitive deficit as a baseline, but we have to make sure, and more importantly, these patients are, first of all, disoriented to time, followed by place. Usually they are able to identify themselves, but most of the time it's the time thing they are able to which goes away very quickly early on. So that should be checked, that if they are off from the day, in how much number of days, if it's like 3 days they're off from the date, or if they are 2 days off from the week, or if they are 4 hours off from the time. So if it's 12 p.m. and they say it's like 6 p.m., so probably they are having the delirium. There could be other cognitive deficits. As we discussed, they may be having baseline deficits as well. So behavioral and emotional abnormalities, as we discussed, this is something which is more noticed by the family or the nurses, because they may be hyperacting sometime, or they may be sometime very somnolent the other time. And sometimes they are having psychosis and hallucinations. So the clinical assessment, when we have a good history from the nurse or the family, we're going to do the physical assessment of these patients. So we need to know the signs of dehydration, if there is any infection or trauma recently. If these patients have autonomic instability, that's a red flag sign. That means they're going to develop more complications, arrhythmias, and the mortality going to be high. Neurological examination is particularly focused on focal neurological deficit, just to make sure if there is a vascular insult that can be picked up early on, and imaging can be ordered as an initial investigation rather than a second-tier investigation. These patients tend to have involuntary movements. When we talk about involuntary movements, it could be tremors, which are usually 8 to 10 hertz tremors, mostly action-related. These patients may be having asterixis, like we discussed in our case, which is a negative myoclonus, or inability to maintain sustained posture. These patients tend to have asymmetric myoclonus as well. There could be carpologia, which means they are picking on objects, which is could be picking off the sheet, picking on the buttons, picking on the objects. Catatonia is flexibly. Usually our psychiatric colleague help us with the catatonia and management of these patients. Coming to the clinical assessment of these patients, which is more directed towards the delirium. So we do confusion assessment method, which I'm going to discuss in my next slide. And there is a forward digit span. In the forward digit span, we start with the 2 numbers and we can go up to 7 numbers. These could be any random 7 numbers from 0 to 10, but they have to pick it up and we have to gradually increase in a way that they have difficulty level. So we go forward and give them 3, 4, and 5. If they are able to pick up to 5, most probably they are not having delirium. But if it is less than 5 digit, they are able to pick, then, or recall, then there is possibility of delirium. Or we can do the spell word backwards. It could be serial 7 testing, which can also give us the idea about the attention of these patients. The A test, or the continuous vigilance test, is a test which I briefly going to talk in my next slides as well. But that is another way to test the attention of these patients. And then there is a alternate response test, which is palm side fist testing, which can be done on the bedside. And then finally, there is an ICU patient, which is a different patient population having more severe pathology, and we're going to discuss about those. So as I said, it's the first two features should be the core features on the assessment of these patients, and the family or the nurse can give us the idea about the change in the cognitive status of these patients. So it's an acute onset and fluctuating course. So these two things we have to confirm with the family or the nurse. The next is inattention. In that case, they are not able to keep their focus or continue doing kind of the same task. It's just like if we ask someone to put the 10 pens together on the table, they won't be able to do that. So it's like they are not able to continue keep doing something in a sequenced manner. And the next two are the optional features. It could be disorganized thinking, where they have the illogical flow of ideas, switching conversation from one topic to another, and unable to keep a sequenced conversation. And additionally, there could be altered level of consciousness, which I'm going to discuss during our ICU assessment and also otherwise as well. So Delirium Index is a scale which is used for assessment of these patients. There are 7 components to that, and these components are divided from 0 to 3 based on the severity. So as we discussed in our previous slides, what we assess for is the attention. So if there is an inattention in these patients, so there is disorganized thinking, and we're going to grade it from 0 to 3. Altered level of consciousness, disorientation, memory impairment, visuospatial disturbance, and motor disturbance. Coming to the CAM-ICU or confusion assessment method in ICU patients. So these patients, first we need to confirm with the bedside nurses if there is a sudden or acute change in the mental status, and if it's fluctuating. If it's not there, which is a core criteria, then this patient is not a delirium patient. If they do have it, then we're going to come to the next part, which is inattention assessment. And for that, that's what I was talking about, the sequence A test, where we ask a patient to tap or squeeze our fingers every time we're going to say the letter A. So you can do it in clinical setting, you can do it in the ICU, even on the patients who are ventilator, they can help you with this testing. So you use the word save a heart or Casablanca. These are the usual ones I use. There are 10 alphabets in it, and there are almost 4 or 5 A's in it. So if there are up to 2 mistakes, which is like 20% possibility of mistake, if there are more, then these patients are actually having delirium, and we should assess for their conscious level. For the conscious level, we do the Richmond agitation sedation scale, and we assess the patients from +4 to -5 based on their agitation to somnolence or coma. For sake of the disorganized thinking, we have to give a task which involved higher cortical functions, as we discussed. So we give them this proverb, if there's like, will a stone float on water? So will they be able to answer that question or not? And they can actually squeeze and tell yes and no, and we can give them the idea that if you're gonna squeeze my fingers, that means yes. So are there fish in the sea? Does 1 pound weigh more than 2? Can you use a hammer to pound a nail? And this is a pyrexia task where they can kind of show you how to nail a hammer and pound a nail. If we can also give a command for patients who are actually weak on one side. So what we can do is, it's like, hold up this many fingers, and you can hold 2 fingers in front of them and ask them to hold 2 fingers. And ask them to, it's like how you do the same thing in the other hand. If they're not able to demonstrate, just ask them to add 1 more finger in the hand they're able to do the first task. And based on that, you can decide this patient is having delirium or not. Coming to the laboratory testing. So once we have completed our history examination, then we can do our laboratory testing to know the etiology of delirium. As we discussed, there are many reasons for that. So complete blood count with differential, urine complete, and especially in US, toxicology screen is very important, especially if it's a young patient. Erythrocyte sedimentation rate, C-reactive protein, looking for any inflammatory or autoimmune process, random blood sugar levels, serum electrolyte, liver function test, urea creatinine, thyroid function test, and arterial blood gases. So these are kind of the basic tests or the first tier testing, and you can add to that based on your initial assessment. Next comes your next tier workup, which includes imaging. Chest x-ray can be done as a tier 1 as well. But if you're not getting to clear diagnosis and patient has focal neurological signs, you should go ahead and get the MRI brain plane or stroke protocol. If the imaging is normal and still we are not getting to the diagnosis and the patient is having delirium, then we can proceed with lumbar puncture to know if there is some kind of brain infection. So there was reporting of 2 cases where there was bacterial meningitis without any fever. So we need to be careful about this rare patient population, but it's a step-by-step approach. Next comes the neurophysiology or electroencephalography. So there was one study which is actually old, but still it was noticed that 10 to 37% of the patients have seizures in the ICU setting, which is a big number thinking about these delirium patients. Now, for the diagnosis, identification and the treatment of the underlying condition is the key factor to help these patients. And sometimes there could be more than one cause for delirium. Now, it could depend on the presentation setting. If the patient is coming in the emergency room, it could be stroke, it could be a toxic screen may be very well needed. Additionally, these patients may need naloxone or thiamine as a initial medication beside treatment for based on the etiology, what we find out on the blood test and the imaging. But the red flag signs for the patients who are presenting in the emergency setting are that if they are having aged more than 60 years, or if they have focal neurological deficit, headache with vomiting, and an altered mental status, we should get prompt workup, especially imaging and MRI brain, to make sure there is no meningoencephalitis or a stroke. Now, assessment and plan. So my patient we discussed early on was having baseline dementia with new onset fluctuating cognitive deficit with normal labs for evaluation, but I had high suspicion for delirium, which was hyperactive based on clinical assessment. There was no clear focal deficit except for plantar response on extensive plantar response on one side. I felt that it is probably because of the recent use of benzodiazepines and pain medication. I decided to proceed with the workup for this as we discussed. So my provisional diagnosis was hyperactive delirium. We asked for the urine complete, chest x-ray, vitamin B12 level, TSH, MRI dementia protocol, and antipsychotic was started on this patient. Now, these patients need prevention and management plan which should be multifaceted. So it's a multifaceted intervention program for these patients, which has been noticed to help in the recovery in almost 43% of the patients who are in active delirium. And this was based on the 22 randomized controlled trials. More importantly, what they need is a nursing education, frequent orientation. So in US, they have whiteboard where they are writing every day, who's the nurse, who's the doctor, what is the day today, and keep orienting them about the environment daily. Sleep hygiene is very important for these patients. Hydration status is one big thing, which seems small, but it is very important. Visual and hearing input daily, guiding them what day is it, what year is it, who's visiting them. Soft music and warm bath is also very important to kind of help them calm down. And more importantly, avoid restraints and immobility. And you can imagine how tough that's gonna be, especially in the ICU settings. Avoid sedatives and treatment of the cause. So the medications which has been noticed are the alpha-2 agonist, which is dexmedetomidine, and it has helped to reduce the ICU stay of the critically ill patients. But in terms of the mortality, it doesn't change much. Also, for the typical and atypical antipsychotics is the most robust data. But again, these patients do get help these medications. But more importantly, or the biggest evidence come from those prevention techniques. Choline esterase inhibitors have been noticed to help these patients, but they doesn't reduce the ICU stay and may worsen the ICU stay. So there is a mixed evidence about choline esterase inhibitor. I'm not discussing about the pathology of the condition, which naturally takes a longer presentation. Otherwise, we can discuss why choline esterase inhibitor is in the list. Also, we should avoid preventive use of medications, because if we use 3 or more medications or new medications in these patients, they actually become more delirious. And 14.8% patients still met the criteria for delirium 12 months after discharge. So some low degree delirium continues on. As we discussed, it's very important to differentiate these patients between hyperactive and hypoactive delirium, because hypoactive delirium has worse prognosis than the hyperactive delirium.